Well, I want to welcome everyone back here to Prescription for Progress. This is Devex's flagship event on the future of global health, and we're so delighted to have all of you with us, joining us from around the world, and really for a very special session, maybe the highlight of this event for me, just getting to sit and speak with Heidi Larson or with Piot individually would be exciting, but getting them both here together, a virus-fighting duo, as they are widely known around the world, it's just great to have you both. So thank you for taking the time to be here. I'll just say a couple of quick words about you. I think people who are here know you both quite well, but of course, Peter maybe is most famous for back in 1976 co-discovering the Ebola virus, identifying it, and then spent a career fighting HIV as the founding executive director at UNAIDS and many years as a UN Undersecretary General. He's now, of course, the director of the London School for Hygiene and Tropical Medicine, and has himself survived COVID-19 and is a special advisor now to the European Commission's president on this virus. So really a remarkable leader in this space. It's fantastic to have you here. And then Heidi Larson is an anthropologist, also affiliated with the London School of Hygiene and Tropical Medicine, and leads a center there, which is focused on vaccine hesitancy. It's called the Vaccine Confidence Project. It's a WHO Center of Excellence, and has really become a leading expert in the world on this growing, emerging, maybe fully emerged issue of vaccine hesitancy, certainly very salient for the times that we're in now as we read everyday news about the latest vaccine. I'm so delighted to have both of you here for this discussion. Thank you. And maybe I can just begin with you, Peter. You know, we're almost at the 1-year anniversary of the WHO declaring this a global pandemic. And so I wonder, as you think about where we are, how this moment maybe is a bit different than where we were in the fight against it and where we're headed. How do you sort of describe the moment that we're in today in the fight against COVID-19?
Yeah. Hi, Raj. Nice to see you again. Well, I think we are kind of getting to the end of the beginning, in a sense. On the one hand, we had, during the current wave, more people dying than even in the beginning, at the beginning of the epidemic. And it seems as if we hadn't learned much in terms of societal response. On the other hand, the biggest difference is that today we have vaccines. Vaccines are there, but they're not available for everybody, but that's a matter of time, I hope, and we have to do everything we can to, ensure equitable access across the world, because otherwise we're all in trouble. If not everybody has access to vaccine, we'll all suffer. Plus, what is also new but not unexpected for us virologists is that there are these so-called variants, mutations. That's what viruses do, and these are new challenges. But I think we now can at least plan for a return to more or less normal, although I don't think we should do that too soon, too rapidly, because then we are guaranteed going straight into another big wave with lots of deaths.
I want to dig into lots of that, including the variants, the emergence of variants. But Heidi, just the same question to you. Generally, how do you see the moment we're in now, a year into the declaration of the global pandemic?
If last year was the year of immediate control, this is the year of the vaccine. I mean, 2021, and we're just at the beginning. This is going to be an incredibly important year for vaccines in general, for the relationship with publics, and it's a huge opportunity to get it right. Yeah, it's the year of the vaccine, I would say, or vaccines, making it even more.
I was going to say, it's interesting when you say the vaccine, right? Because for so many other viruses, we are used to going and getting the vaccine. We don't really think too much about the manufacturer or the type, but this is a very unique case where the whole world is very tuned in to the many vaccine candidates that were in the pipeline, then the ones that have gotten emergency authorizations, the ones that are available in their country or in their clinical setting. It's starting to be, it's a different scenario. And I hear people talking about which vaccine are you getting and which one will I get? And in fact, we have now the case, a really important case in South Africa with their variant, possibly from one small study, not being effectively dealt with by the AstraZeneca Oxford vaccine. I wonder if, Peter, maybe you and Heidi both want to weigh in on this issue of the emergence of the variants, the battle against those variants with vaccines, our limited knowledge and understanding as we go through, and how to approach this.
Yeah, it's indeed new, but one thing that I think we should also realize is that we're in for the long haul here. We have to prepare for societies living with COVID. I know that some people talk about zero COVID, but that's an illusion. I mean, only one virus that infects humans has been eradicated, eliminated, and that's smallpox. And that took a major effort. And maybe we'll get there over time, but I don't think so. This is a very smart virus. It mutates all the time. So that long-term strategy, we need to look at it right now while we're dealing with the crisis. And the crisis is, among other things, because of the appearance of variants. And the more we sequence, the more we will find, because that's what viruses do, they mutate. And the biggest fear, of course, is that these new variants will be more transmissible, and that's already proven for example, the so-called British variants. They have impossible names, B1117, or particularly whether they make vaccines ineffective. And fortunately, up to now, there's at least from particularly the South African one, from a trial with the Janssen, the J&J vaccine, that showed that it was less effective for mild disease, but in terms of preventing severe disease, hospitalization, and death, it was as effective as the trials in the US. And that's what we're really after with vaccines, preventing people from getting hospitalized and keeping out of the hospital, keeping them from dying. That's the number one priority. We have to prove this now for other vaccines as well. So it won't be an all or nothing thing, but what's key is that we now prepare for the eventuality that variants will, just make vaccines ineffective. So that's now another race against the virus.
So do you expect then we're seeing a situation, and maybe either of you, Heidi, too, you want to jump in on this, where we'll likely all be getting, when we have access, depending on our country, get access to a vaccine and then getting boosters maybe in the first year, and then in the future getting 1 or 2 vaccine shots every year kind of for the rest of our lives? Is that something we sort of should expect to happen? It certainly brings in the question of vaccine hesitancy as a public health issue at a much higher level, if you think of it in those terms.
Well, I mean, I think it's another uncertainty that feeds into the hesitancy issue. And I think part of what's allowed the hesitancy to thrive and the anxiety to thrive so much is the level of uncertainty. Peter's better to speak about the possibility of boosters, and I know that that's certainly been in discussion, but I think people will accept boosters if they need them. What people are uncomfortable with is the constant changing, the uncertainty, the not knowing, is it worth the risk if it's not even the right one? So I think it's really, we underestimate the ability of publics to get on board. But there's some basic things they need, which is 1, trust, 2, consistency, and then some evidence that it's actually making a difference.
Right, and uncertainty is kind of part of, it's the name of the game when you're fighting a novel virus, right? And we're developing new vaccines. There's going to be uncertainty, but I guess how we manage that is really key here. And I think about the case of South Africa in particular, the country having to make this decision. How do you feel about that, Peter? I know the African CDC has said, no, we should go forward with the Oxford AstraZeneca vaccine in other countries that have already made contracts to buy it and receive it. They should. It sounds like maybe from a public health standpoint, the issue is just get as many people vaccinated with any approved vaccine as quickly as we can. Is that the way to think about this?
Oh, I was very impressed by the very rational decision-making in South Africa. One of the mantras of many governments have been during this epidemic, we follow the science. Whether they do that or not, that's another question. That was very variable. But in South Africa, when it was shown that the AstraZeneca Oxford vaccine only protect about 10% protection, that's basically not much against this variant, then they said, we're not going to use that. We're going to go for the Janssen vaccine, which showed this very high protection. It may still work, the AstraZeneca vaccine, for severe illness and deaths, but there are no data. And I totally endorse what the Africa CDC did. So I just can't understand why WHO's SAGE committee recommended the AstraZeneca vaccine also for countries where the South African variant is prevalent. I mean, I certainly supported it's a very good vaccine, the rest of the world, but there are no data. And so at the moment, I would say that where we're going to is probably not an annual type of booster. You never know. But I would expect that as more and more people are vaccinated, plus all the ones that are not vaccinated, there will be more variants coming up. But it may be a defined spectrum. So let's say that there are 4 or 5 variants we know that are really problematic for vaccine protection. And then companies can develop vaccines that will protect against these ones. That's not impossible whatsoever. That's technically possible. It's the manufacturing, it's the approval. And then we could go indeed to a system where now and then we need a booster, because we also don't know how long is the protection going to last. Is this 1 year, 5 years? For measles, it's lifelong. All unknowns, and managing uncertainty, as you said, has been probably the biggest challenge for individuals, for societies, for decision makers. And we really have to, to learn while we're sailing, or racing is probably a better word.
Heidi, is the issue of vaccine hesitancy here a rich country problem? Is hesitancy an issue we need to worry about in the global health community too, when we think of low income, low resource settings? Or is it really a rich country problem in France, in the US, the UK, et cetera?
Oh, it's totally global. It just plays itself. I mean, I've just finished a 15-country study with Africa CDC across the continent, and there's some serious issues of refusal and distrust. And not everywhere, but and even aside from COVID, we've seen this with other vaccines. It's very much about relationship with government. It's about trust. If you're doing well with your government, you're going to be much more open to these things. But there's a lot of factors, but it's not at all unique to the wealthier countries. And I think that's been a bit of a surprise to the global health community to see. It emerges in different ways. It's very unique, even the difference issues with different vaccines.
And we've just got a couple of minutes left, but briefly, Heidi, to the global health community, what should we be doing, or at least thinking differently about this? I know your center is partnered with Facebook, and there's always this tension between social media maybe helping to fuel these things, but also possibly being part of the solution. How should organizations that work in global health be thinking about this differently?
I think we're always quick to kind of take the, push it out there approach, and they'll come get it, and then we'll deal with the hard stuff when we get there. We know where the issues are in the population around vaccines. That's reasonably predictable, but I think we do need to keep surveying and listening. But I think we should start there first, or at least start there early, and we should be out in the communities. We know we're going to face challenges, listening to them, engaging them, making them feel like actually you care about what they think. If we don't get that engagement going now, before these vaccines start rolling out, we're going to miss a huge, important opportunity.
And Peter, just as we wrap up, is this the virus? Is COVID-19 the thing that changes our thinking as a global health community? We kind of thought maybe Ebola in West Africa would do it, and people would care more about pandemic preparedness, and countries would invest more and see a minimum health system we all need to have. That didn't really happen. Do you think this will do it? Do you expect to see or want to see something change in the global health kind of dialogue coming out of this?
If this pandemic doesn't do it for global health and for, actually, I would say also putting equitable partnerships on the table, then I don't know what it will do. One, it shows clearly that health is truly global. Two, this was not an epidemic that when you think from Europe that came out of Africa like Ebola. No, it is the other way around. The first cases came from Europe, came from Asia. And I think this needs to lead to a new world order in terms of health, and that we need to invest in infrastructure, in systems for epidemic awareness and preparedness, but also the health systems in these countries that are less fortunate than the high-income countries. But even high-income countries, UK and US haven't done exactly a great job. UK is doing a good job with vaccination, but now we need to vaccinate the whole world. That's key, otherwise nobody will be safe. And secondly, we should not relax too fast with all the measures, because otherwise we'll be in trouble again. And thirdly, we need to prepare for the long term, for the next pandemic, and invest in it. It's not going to be cheap, but it's much cheaper than having a crisis at a global scale as we have now.
Well, let's see what comes out of this. I know the community of people watching this and part of Prescription for Progress are the very people who are at the forefront of trying to shape this new reality. And it's been a real pleasure to hear from both of you and give us some inspiration and some guiding light as we go forward. I'm glad you're well, Peter, and it's really nice to see you both. Thank you for being here.